Good morning. Welcome to Medical Grand Rounds. It's certainly my pleasure to introduce our Grand Round speaker this morning. Dr. Alexis Eastman came here from Pennsylvania to go to the UW undergrad for her biochemistry degree, then stayed on for her medical degree, her training in internal medicine, and her geriatric fellowship. We were fortunate enough to retain her in 2014 as a clinical assistant professor. In 2016, she received the Physician Award by the Department of Medicine House staff and was named a top doc in Madison by the Madison Magazine. We're very happy that she's here to present to us Danger Everywhere, What's New in Geriatric Prescribing.
So thank you, Alan. Okay, apparently that's on. That sounds good. So I slammed my hand in the car door last week. I don't think I broke it. I mean, I'm certainly not going to go to the doctor about it because, doctors make the worst patients. But it really hurts. So if you have CC'd charts to me in the last week, I have not read them because I discovered that it really hurts to scroll all the way down to the assessment and plan and find out what it is you want me to do. So next week, I'll do it all, I promise. But that made me think, here I am. I'm a geriatrician, right? I talk about medications all the time and how we're supposed to cut them down. And here I am scrolling through my patients' medication lists for seconds, so long that it hurts my hand. So that brought home to me, this is a timely topic. So today we're going to talk about Danger Everywhere, the update in geriatric prescribing. I aspire someday to have disclosures. We'll work on that. So what are we going to talk about today? Well, we're going to talk mostly about old quandaries with new data, and that's our proton pump inhibitors, our statins, hormone replacement therapy, and tramadol, which you may not have known as an old quandary with newer data. We're going to talk a little bit about the geriatric sacred cow, and we're going to talk about the dangers of don't. Maybe my way is not always quite correct. We do underdiagnose, undertreat, and underprescribe for certain conditions. We're going to talk about exercise. The short answer is yes. We're going to talk about reasonable prescribing, some future possible solutions, and summing it all up, of course. So by the end of this talk, I hope that you understand the link between proton pump inhibitors, chronic kidney disease, fractures, maybe dementia. Understand whether or not there's a link between statins, diabetes, chronic kidney disease, dementia, and stroke. Is there a use for statins as primary prevention? The limited use of hormone replacement therapy, but the real use. That tramadol equals delirium. You won't forget osteoporosis, cancer, and depression in your older patients, and you'll know how to prescribe exercise. So in the clinic, I have a lot of conversations that start off like the following. I need to stop X. I read it causes Y. I never want to start X. I hear it's dangerous. What can I do to prevent, which usually involves X? And because I take care of a lot of retired academics, I brought you this article on. Always good. So let's talk about old quandaries and new data. First, proton pump inhibitors. They've been in the news a lot. This was my completely unscientific survey of my colleagues to find out what's been in the news, what their patients have asked them, and that's what we're talking about. So proton pump inhibitors, old concerns. I'm not going to talk about C. diff. I'm not going to talk about pneumonia. I'm not going to talk about magnesium, calcium. A little bit, I'm going to talk about bones. So it all ties together. We are going to talk about chronic kidney disease, dementia, and fracture risk. So JAMA this year had a cohort study, 10,482 patients out of the Geisinger trial, Geisinger system, and a retrospective validation cohort of 250,000 patients. And they ran an analysis of those on PPIs versus those in H2 blockers and who developed chronic kidney disease and came up with a hazard ratio of 1.4. when they did a propensity score match comparison, that hazard ratio bumped up to 1.7. Now, the absolute risk difference was small, 3%, but it was a real finding. BMJ Nephrology followed suit with a case-controlled trial of 76,000 people without CKD over 7 years and found that the incidence of CKD had an odds ratio of 1.1 and that the incidence of mortality had an odds ratio of 1.7. That's pretty compelling. Now, this was a VA trial, and it was interesting to me. They found that proton pump inhibitors had less diabetes, less COPD, less coronary artery disease, and less cancer than the control group. Fascinating. I don't know what that means, but fascinating. And it was more likely to happen in younger patients. And I thought about that, and I thought, well, why is that? Oh, most of my patients already have chronic kidney disease. Hard to get it if you already have it, right? Hot off the presses, the Journal of the American Society of Nephrology had a 5-year trial of new proton pump inhibitor users versus H2 blocker users. And they found that the incidence of CKD had a hazard ratio of 1.28, somewhere in the same range as the other studies. But what I liked about their study is they looked at the doubling of creatinine with a hazard ratio of 1.5 and a progression to end-stage renal disease with a hazard ratio of 1.9. So in my world, that's more important. If the vast majority of my patients already have some chronic kidney disease, but their proton pump inhibitor is going to almost double their progression, their risk of progressing to end-stage renal disease, that's serious stuff. And they found a graded association. So longer proton pump inhibitor use was equated to worse renal outcomes. And I've got patients who've been on proton pump inhibitors as long as they've been on the market, which I don't even know how long that is anymore. But a long enough time. Worries me. They're now over the counter in big bottles at Costco, right? Now, the drawbacks to the study is that they don't really talk about the indication for the proton pump inhibitor. So they don't address the possible risk of stopping it. If that pantoprazole is the only thing standing between my patient and their GI bleed recurrence, that's important. Right? Maybe they need to stay on it. And none of the studies really looked at over-the-counter use. Now that there's over-the-counter proton pump inhibitors, they may or may not report that to the study coordinator when they call up and say, well, what medications are you taking? But overall, this is a pretty worrisome trend. Let's talk about proton pump inhibitors and dementia. So I'm about to show you some data that I would normally not put on a slide. But I'm putting it on a slide because it was the study that made the news initially, and all my patients came in with the article. So I put it on a slide. It's the Alzheimer's Research and Therapy in 2015 took a group of 60 patients, put them in 6 groups of 10, gave 5 of those groups proton pump inhibitors and 1 group as a control. They did cognitive testing at days 1 and day 7 over a week and showed that proton pump inhibitors had a cognitive decline. I don't really know of any study that looks at cognitive change over a week as it relates to a medication, unless you're delirious. So I find this study to be relatively insignificant, except that it engendered lots of other study. So that's what happens when you make the news, right? So the European Archives of Psychiatry and Clinical Neuroscience, at the same time, had a cohort study of about 3,000 patients that did show a connection between proton pump inhibitor use and dementia. 1.4 was the hazard ratio, give or take. But a better study came out of JAMA Neurology this year. This was a prospective cohort study of 74,000 patients over the age of 75. And they looked, and it was an insurance database cohort out of Germany. And they looked at any proton pump inhibitor and new dementia diagnosis. And they found that there was a hazard ratio of about 1.4. Gastroenterology published a very thoughtful critique of this. It was actually really nicely done. And they pointed out that relying on insurance coding for dementia diagnosis is inherently problematic. Some of the patients had 2 types of dementia listed as diagnoses, like not just dementia and Alzheimer's, but like frontotemporal and Lewy body, right? So kind of disparate looks. And that there wasn't very much data on the adherence, or few risk factors are included. But that's still worrisome. So these are worrisome trends, and I'm sure we're going to see a flurry of papers in both places going forward from here. Let's talk about proton pump inhibitors and fractures. This is not entirely new, but there was a really good new meta-analysis of 244,000 fractures. I like that Osteoporosis is this journal that can review 244,000 fractures in outpatients. It's great. They showed a relative risk increase of hip fracture, spine fracture, and any site fracture in the 1.2 to 1.6 range. And otolaryngology head and neck surgery of 2016 also showed the same graded association, that your risk of having these fractures goes up the longer you're on proton pump inhibitors. Now, the nice thing about osteoporosis is that we can treat it. It's not like dementia, and it's not like the difficulty of treating chronic kidney disease. It's something we can actually do something about. And way back in 2012, Osteoporosis International ran a study, published a study that showed that risedronate reduces the risk of fracture regardless of your proton pump inhibitor use. And actually, the people on proton pump inhibitors got more benefit out of the risedronate than the non-proton pump inhibitor people. So that's useful. So there's one area we can succeed in. So what to do with this information? Well, I think it's important to remember that proton pump inhibitors have a use. There is an indication. They're excellent drugs. They work really well. So they should remain standard protocol for certain things. But maybe we need to taper them as possible, right? They're not necessary forever. If you had a GI bleed, you get your pantoprazole, you get something else later. Maybe we should be using H2 blockers more. There's some quibbling in the literature about famotidine versus ranitidine, but effectively we should probably be using them more. Very questionable whether or not you need to be on GI prophylaxis for the 81 milligrams of aspirin that pretty much all of us are now supposed to be on for one indication or another to prevent certain doom, right? And the risks are still relatively small, so we should have quality of life discussions. I have patients who have tried multiple times to get off their proton pump inhibitors, but they're miserable. They're nauseous in the morning, they can't enjoy their coffee, and that's torture, so we shouldn't do that to people. Now let's talk about statins. So in terms of statins and dementia, actually, it's very equivocal data. Cochrane in 2016 and others have shown no correlation really between statins and dementia, no benefit, but also no clear evidence of causation. And this goes against what my patients are always coming in and asking and saying, you know, I hear that statins are going to give me dementia. The study that really sparked that is a study that I couldn't even bring myself to give a slide to. It was a study of 22 patients that showed a statistically significant but clinically insignificant change in cognition with statins. It's a tiny study. Couldn't bring myself to put it up here. All right, we'll just keep talking. It's going to be one of those days, apparently. So there's limited data on high-intensity statins. There is some data done by Cindy Carlson and company that shows some increased long-term blood flow to the brain using when people are on atorvastatin. But that may or may not pan out as a surrogate marker. And generally, Cochrane notes that there's poor quality, there it is, trials that confound the data. The Mayo Clinical Proceedings also had a meta-analysis of 27 studies that showed that statins decreased 5 studies in there showed that statins decreased dementia, but the remainder 22 didn't really have an impact. So again, we're kind of left with this wash of do they actually have an impact or not? Big question mark. Statins and chronic kidney disease, sort of the same thing. So there is some data that high-intensity statin use may slow GFR decline, but that low or moderate-intensity statins don't have much effect. The Cochrane 2014 trial on this showed that in people with chronic kidney disease, statins are associated with a 20% reduced risk of cardiovascular mortality. It didn't have any side effect reporting, and there was an unclear effect on chronic kidney disease progression. So, slightly smaller question mark. Might help, doesn't seem to hurt, no clear idea. Statins and diabetes, different story. So the Lancet in 2010 had a meta-analysis of 13 trials, 91,000 patients, and came up with a 9% increased risk of diabetes in people on statins, with a number needed to induce of about 225 people over 4 years. The Journal of General Internal Medicine in 2015 did a retrospective cohort study, 26,000 patients, and showed an odds ratio of new onset diabetes of about 1.87. Now, the relevance to the geriatric population is probably relatively mild. In my younger patients, the 65 to 80 kind of crowd, they can still get diabetes. Sure, so we watch this. But in my 80-year-olds and older, if they don't have it already, they're probably not going to get it. I mean, these are the people I'm prescribing milkshakes to, right? It's not going to happen. What about statins and strokes? Well, Drugs and Aging in 2015 looked at 8 randomized controlled trials, 26,000 patients, and they didn't really have any significant impact of statins and strokes one way or the other, fatal or non-fatal. Now, the Journal of the American College of Cardiologists in 2013 looked at a slightly different set of 8 randomized controlled trials of people at high cardiovascular risk and showed that statins do decrease non-fatal stroke risk by about 24%, with no effect on mortality. So another question mark. Do they, don't they, do they, don't they? They might help, they don't seem to hurt, again. Statins as primary prevention. So there's some difficulty, as you might be able to tell from these slides, about studying older patients and statins. One of the problems is that older patients are a more heterogeneous group than younger patients. So very widely varied comorbidities and frailty scores and things like that. Nursing home patients are studied in nursing home studies. They're not studied in general studies. So the vast majority of trials, including everything with a catchy name done by cardiology, usually studies non-nursing home patients. So that decreases its real-world applicability. Chronologic age does not equal vascular age. We all know this. All you have to do is walk out of this building, walk past the smoke shack, and you will know that chronologic age and vascular age are not connected at all. And cardiovascular risk factors are less predictive in older patients, in large part because comorbidities and frailty really confound the effect of cardiovascular risk. So that makes it hard. I have a very earnest junior faculty. I'm a very earnest junior faculty member, and so I have a lot of conversations that go a lot like this. Well, your risk of cardiovascular problems is about 38% over the next 10 years. A statin would cut that to about 33% with minimal side effects. And then the very astute and witty older person says to me, you know, a heart attack's not really the worst way to go. To which, earnestly, I usually reply, well, most of my patients are more afraid of the heart attack or stroke that doesn't kill them. To which one very witty older person told me, so what you're really saying is that I should do everything that's bad for me to make sure it does. Right. Fail. I'm going to rewrite my script, I think. But you know, it's out there. So statins as primary prevention. So Journal of American Geriatric Society looked at this in 2015. They looked at 16 studies, 59,000 people on statins, 59,000 people not on statins. And what they did, interestingly enough, is they looked at mortality and compared low cardiovascular risk, high cardiovascular risk with low and high non-cardiovascular mortality risk. And so they found that really what mattered was your non-cardiovascular mortality risk. So your cardiovascular mortality would go down with statins if you had no other risks that would cause you to die. Right? So as the same astute patient said, so if you drop my risk by 5%, what's going to fill that gap to kill me? I don't know. And so the relative risk was actually about the same for low cardiovascular risk and high cardiovascular risk, provided they had a low non-cardiovascular risk. If they had a high non-cardiovascular mortality risk, there was no benefit to statins at all. Didn't shake out. Now, the same trial I referenced in terms of stroke, the Journal of the American College of Cardiologists, looked at people with high cardiovascular risk only, and they did show a decreased risk of heart attack by about 39%, which is huge, but no effect on overall mortality. And it's hard to know because it's not really shaking out in that data about whether or not they had a high non-cardiovascular mortality risk or not. And the Journal of Geriatric Cardiology looked at a Jupiter subset and showed a 48% decrease in non-fatal cardiovascular endpoints. Again, huge. And with a number needed to treat of 24. So that's really compelling. So for some people, statins as primary prevention are probably a good choice, especially in your patient population. Additional considerations. So in Circulation, 2016, they looked at 6,500 middle-aged men. This was the Western Scottish cohort. So these are the Welsh and Scottish. These are my people, the pasty, beer-swilling people of the North. They put them on 5 years of pravastatin and showed a decreased mortality. And what I really thought was elegant about this is that they showed that that benefit lasted beyond the study. When they were all off their statins, they still had a decreased cardiovascular mortality for several years thereafter. Now, because we are in a modern era and we have to worry about such things, there is an interesting study from cardiovascular drug therapy in 2015 that shows that the cost effectiveness of statins decreases the older you get, the shorter your prognosis is. From a lifetime incremental cost effectiveness ratio of 33,000 to 161,000 if you have less than 10 years to live. And one thing that the pharmacist always reminds me is that there are many drug-drug interactions. And atorvastatin and simvastatin go through the CYP3A4 system. So that's important to remember because there's lots of interactions. They're all listed at the bottom of UpToDate. So on the pro side, decreases cardiovascular events, possibly decreases strokes, may help slow the decline of GFR, and the benefit seems to last beyond the use for 5 years. On the con side, no effect on mortality in my patients, lots of drug interactions, limited data on high-intensity statins, increasing the risk of diabetes, and if you have a high non-cardiovascular mortality risk, there's really no benefit. So this is the compromise I've decided on. All of you who are primary care internists taking care of younger people, you prescribe the statins for 5 years. When they come to me, I'll stop them. Everybody will win. It'll be great. So let's talk about hormone replacement therapy, because I get a lot of questions about this now. Is it back in? It seems like it maybe is back in. The North American Menopause Society in 2015, I did not know there was a North American Menopause Society actually until 2015, until I found this. I'm very impressed. I'm very proud of us. Showed that vasomotor symptoms of menopause last on average 7.4 years. 7.4 years. And that 42% of women ages 60 to 65 have moderate to severe symptoms. It was a revelation to me. I thought, oh my God, I'm in for like 7 years of torture. What is this? This is horrible. No one talks about this. Why don't we talk about this? It's awful. And then they don't say that. They say, use judiciously after a discussion of risks and benefits with your patients. Again, when you're talking about like waking up in the middle of the night drenched in sweat, I don't know about use judiciously after discussion of risks. It didn't seem like that to me. So, but there are real risks. So we talk about bone health. Usually we think of hormone replacement therapy as being really good for the bones, right? And the International Osteoporosis Foundation found that hormone replacement therapy equates to a 30% improvement, reduced risk of fractures. But when they compare that to bisphosphonates and raloxifene, they really find it's less effective at prevention and has much more long-term risk, which we'll sort of get to. A lot of people ask me about sleep. I get more questions about hormone replacement therapy and sleep than I do about anything else in terms of hormone replacement therapy. Endocrine in 2016 ran a meta-analysis of 7 trials, and they did show that if you have vasomotor symptoms, you have improved sleep on hormone replacement therapy. Well, that makes sense. You have a whole bunch of night sweats, and then suddenly you don't. You're going to sleep better. Interestingly enough, they said there were too many quality limitations and too much heterogeneity to actually be statistically proven. So common sense is not always backed up by data. In terms of breast cancer risk, in 2015, the Journal of the National Cancer Institute re-examined the Women Health Initiative data, and I think that was Dr. Chablowski's work. And they showed that estrogen plus progesterone did increase your risk of breast cancer with a hazard ratio of 1.3. Estrogen alone decreased your risk, so it might be a good option for your patients who've had hysterectomies. And the Journal of Clinical Endocrinology and Metabolism looked at the same sort of thing in 43 trials. Again, and they looked at mortality, showing that estrogen plus progesterone increased breast cancer mortality with a relative risk of 1.9, but estrogen alone did not. And there was no association with other cancer mortality. There's a Cochrane Review Update 2015, 6 new studies, end of 19, right? No effect on cardiovascular mortality, regular mortality, non-fatal MI, angina, or time to revascularization. This came up because when I was talking about this talk with another one of my colleagues, she said, what about clot risk? There it is. So your risk of stroke has a relative risk of 1.2, venous thromboembolism 1.9, pulmonary embolism 1.8. Interestingly, That's really only if HRT is started after you're 10 years out from menopause, so when you're beyond that 7.4 years on average, although that's only an average. And there was a decrease in mortality and cardiovascular death if you were less than 10 years postmenopausal. So that was very interesting. So what to do? Well, the Endocrine Society fortunately gave us a practice guideline that says use if under age 60 or less than 10 years from onset, to which I've added a couple things. It's not first choice for bone health by all standards. But we should use it for menopause symptoms because 40 to 42% having moderate to severe symptoms is significant. Don't start if it's been more than 10 years, so I'm not starting it in my patients, sorry. And don't forget topicals. We tend to forget that atrophic vaginitis is a significant quality of life problem for my patients, and we tend to forget to recommend topical estrogens. Now let's talk about Tramadol. This is like my one set of inpatient slides. All right, so inpatient people, this is your chance. What is Tramadol? Tramadol is a non-selective mu kappa delta opioid receptor, SSRI and SNRI. Interestingly enough, I found that there is a kappa delta fraternity, but not a mu kappa delta fraternity. I thought that was wild. They have the greatest little crests. It blocks ascending pain signals. It alters cortical pain perception. It's only 30% reversible with naloxone. The mu action is mostly from a metabolite called O-desmethyltramadol, which has 200 times more affinity for the mu receptor than tramadol does itself, and has a 3-hour longer half-life. So it hangs around a lot more. So that's important. Shockingly poor evidence that tramadol works for perioperative pain control. Very, very limited. Not very good, which is interesting because it's on protocol postoperatively for a lot of European countries. There's really good evidence on my side of things that it works for chronic neuropathic pain. So outpatient land, not so bad. Inpatient, not so useful. It's metabolized through the CYP2D6, which means it has a huge number of interactions. It's going to be huge. It's less addictive than opiates. That's why we like it, right? Less addictive, and it doesn't have the respiratory depression. So some good qualities. So shout out to Josh Vanderloo who sent me this study. It's an excellent study. Annals of Surgery 2010 looked at 118 patients over 75 years of age who were getting major abdominal surgery. They had a geriatric assessment pre-surgery and post-surgery and co-management of their delirium. Isn't that a wonderful thing? The post-op pain control, everybody got IV acetaminophen. Everybody. It's a French study. So we don't do enough of that here, probably. And they either got randomized to a PCA or epidural morphine or IV tramadol, 300 milligrams of IV tramadol a day. Whew. But there it was. Only 28 of those people got delirium. I was actually impressed by the low number, geriatrician assessed, of delirium that happened. These were really healthy people, I think, getting this major abdominal surgery. Of the 28 that got delirium, 22 of them were in the tramadol group. Only 6 of them were in the morphine group. And when they did the Cox regression analysis, they found that the 3 independent risk factors for developing delirium in this cohort were tramadol, an American Society of Anesthesiology score of 3 to 4, or a time to get up and go time before surgery of greater than 20 seconds, so kind of a frailty indicator. The mortality rate was 14% in the delirium group, but only 3.3% in the no delirium group. So the same number of people, but a much lower rate of mortality. Fortunately, in the 24 people who lived with delirium, the delirium resolved. So versus opiates, there are actually very few studies on a lot of these medications in delirium. A lot of case reports, a lot of giant studies that sort of look at ICUs and try and shake out all the various different things that can cause delirium, but there aren't a lot of like this equals that studies. Aging and Clinical Experimental Research in 2016 looked at a meta-analysis of 5,300 total hip arthroplasty patients, a pooled analysis, and they did show that morphine is correlated to delirium with an odds ratio of 3. On the other hand, the Journal of Arthroplasty in 2014 did a case control of total joint patients and found that not only did opiates of any sort correlate to delirium, but mixing up your opiates didn't correlate to delirium either. If you had 2 opiates, still no significant connection to delirium. I thought that was interesting. But again, these are small trials. These are small cohorts. There's just not a lot of data out there. So on one hand, we've got tramadol increasing delirium in one relatively good study. Bias included geriatricians, so I like it. Not good for post-operative pain, and slightly less addictive than opiates, with no respiratory depression. We've got opiates, which are sort of unclear if they cause delirium or not. We think they do, but we don't really know. Are really good for post-operative pain, are possibly addictive, although you could argue that in the post-operative hospital setting, that's probably not the issue, and do cause respiratory depression. So overall, opiates are likely safer in post-operative patients. So that's an interesting take-home message. We always prescribe tramadol because it's a Schedule III. It's a lot easier. But maybe the opiates are safer. So I'm going to probably, I don't know how much time I'll run over. So I'll try to hurry through some of this maybe, but I'll try to get the take-home points in. I'm going to talk about the dangers of don't. I think some of you know that I'm sort of famous for saying I want T-shirts with an upside-down Nike sign on them that say they just don't, UW-Geriatrics. Right? Still want them. I think they're great. But maybe not always. The dangers of don't. Underdiagnosing, undertreating, underprescribing. We do it. We're all guilty of it. And the first place where we're all really guilty of it is in osteoporosis. So there was a cross-sectional observational study of 109,000 women with osteoporosis. And they found out that 71% of them were not on osteoporosis treatment. And that 76% of those who had baseline fractures were not on osteoporosis treatment. And the strongest risk factor? That somebody else had treated them before. I guess we're really cautious about going there again somehow. Like, oh, they've been treated. There's nothing else we can do for them. Another retrospective cohort of 126,000 women with osteoporosis showed that 72% of them didn't actually get treatment within the first year of diagnosis. So no one had treated them before, and we still didn't treat them. Only 28% of those women had had some sort of GI event, but those with a GI event were 76% less likely to be on osteoporosis treatment. Maturitas. I love the name of that journal. What a great name. We should have more Latin-named journals like that. That's great. Looked at Denmark, right? It's easy to look at Denmark. They've got all this data. And they looked at population DEXA screening and noted that it declined markedly with age, down to 1.2% of the population per year in the over 80 set. Unfortunately, they also found that age over 80 was the dominant risk factor for a fragility fracture with an odds ratio of 2.4. I'm really guilty of this. I don't screen a lot of my older patients, the people above 80. I probably should be. The Journal of the American Medical Director Association. Here's your nursing home trial, right? Nursing home patients. 39,000 incident fractures. The 5-year risk of a second fracture was 13 to 43%, depending on the type of fracture. The number needed to treat to prevent a second fracture was 8 to 46, depending, again, on the type of fracture. That's statin land, right? That's secondary prevention land. That's good numbers. We should be treating them. Because a hip fracture has a 20% mortality at 1 year, which is huge. And that's not even talking about morbidity and moving to a nursing home and all the things that my patients hate doing. So the take-home message is, when should you stop screening? There are no guidelines on when to stop. So maybe we should just keep going. It's not invasive, not a lot of false positives. No one really questions your DEXA scan efficacy. Maybe we should keep going. And don't let prior GI events stop you. GI bleed when you were 20 does not mean you can't be on something when you're 70. And there's lots of other treatments, right? It's not just Fosamax or nothing. Let's talk about breast cancer. We've done an amazingly good job with breast cancer. Since 1990, the 10-year absolute death risk in women is down 15.3% if they're aged 50 to 64. It's only down 7.5% if they're over 75. In a study from 2003, they looked at 400 elderly women with breast cancer, and half of them were undertreated. Now, there aren't that many studies on older breast cancer patients. But the studies we do have show that they benefit equally from adjuvant therapy to those who are in the younger cohort. But they have a lower therapeutic index, so they do have more side effects. And I think that's what makes us nervous. Fortunately, there's a growing body of evidence that these geriatric oncology hybrid clinics really help improve tolerance and appropriate prescribing. So the people who have these co-management models do better and they can be more appropriately prescribe the right adjuvant therapy for them. So what to do with that? Well, don't forget that adjuvant therapy works in older women. You can treat them for their breast cancers. Just have to watch for side effects like everything else in older patients, right? And we have a Gerion clinic. Consider sending them there. Maybe it will help. Geriatric depression, another thing that's near and dear to my heart. 50% underdiagnosed. 50%. We're missing it. Why is that? Well, geriatric depression is different than depression in younger people. Geriatric patients don't get sad. They don't do sad. They do meh. They feel more pain. They have headaches. They have more anxiety. They might have concentration issues that look a lot like dementia. They might get more irritable and more grouchy, which I might miss because I kind of think that's cool, right? So I might not notice their depression because I'm so busy being charmed by their grouchiness. There's a lot of overlap with comorbidity symptoms, right? Are they tired and having difficulty concentrating because they're hypoxic from their COPD or their heart failure, or are they depressed? That's hard. That's hard. In 2005, there was a cohort study of 12,000 patients with new antidepressants. 43 of them were supposedly taking a suboptimal regimen by this study. So there was some overlap there. 35% of them were on too low of a dose, 19% too short of a duration, and 15% with inadequate follow-up. In part, I think this is my fault. They've surveyed primary care physicians, and all of them have listened to their geriatrics colleagues when we say start low, go slow. They have all listened to us because they really prefer lower than recommended doses, and they don't increase them if they're ineffective. So we forgot to tack on the start low, go slow, but maybe don't stop. Heart of things. So the take-home points there is that geriatric depression presents atypically, and don't be afraid to increase the doses to the ones that are actually recommended. Then if they don't work, you can switch them. That's okay. So start low, go slow, don't stop. And last, we're going to talk about exercise. It's so versatile. Exercise is great. I found the most efficient study ever talking about exercise. The Scandinavian Journal of Sports Medicine, no stereotype there, published Exercise as Medicine, Evidence for Prescribing Exercise as Therapy in 26 different chronic diseases. We're done. We can all go home. It fixes absolutely everything. All of your psych disorders, your neurologic disorders, your endocrine disorders, cardiovascular, pulmonary, pain, cancer. They didn't even put falls up there. We have 27 now disorders if they'd included falls, right? It's great. But I like talking about dementia. So we're going to talk about exercise before dementia. There was a great JAMA Neurology 2015 study done by people here, amazing people here, that looked at insulin resistance and its effect on cognition. So if you had higher peripheral insulin resistance, aka you're getting to be diabetic if you're not already, you had decreased brain glucose metabolism. If you had this particularly in the left medial temporal lobe, who can point to that? Probably just Dr. Gallagher. You had a decreased immediate and delayed memory score in your cognitive testing. So that has been furthered by excellent work being done by Ozioma Okonkwo and others on exercise and the prevention of dementia, which is ongoing and really fascinating. And Cochrane feels that the evidence is insufficient to really make a recommendation, but endocrine does not. And they recommend preventative exercise prescriptions for all type 2 diabetes patients to prevent dementia specifically. So, writing's on the wall. Exercise during dementia has a much larger body of evidence. So the American Journal of Geriatrics and Psychiatry in 2015 had a meta-analysis of 18 trials. Exercise was better than our medications. Not necessarily surprising because, full disclosure, memory medications are not that great. Medications had a mild effect with a standardized mean change of 0.23. But exercise had a moderate to strong effect with a standardized mean change of 0.83. That's pretty good. It's 3 times better than a medication, give or take. Exercise in another study improved cognition with a standardized mean difference of 0.42. No side effects, remember? They found that aerobic exercise is better. High to low intensity both work. And Cochrane agreed. So now we can all go home. So how do you write an exercise prescription? The first thing is to write it down. Your patients will take you more seriously if you write it down for them. The VA's Move It groups and the American Academy of Family Practitioners are really ahead of the curve on this one. They follow the FIT-PRO model, frequency, intensity, time, type, and progression, and they focus on the rate of perceived exertion more than the heart rate. We try to fit it into people's lifestyle. Brisk dog walks, taking the stairs. I go out to Sauk once a month, and they've got posters up that say, by taking the stairs, you have burned this many calories. By taking the elevator, you're not using this many calories, right? Very, very useful. Exercise class with friends. I try to get 2-for-1 specials. They can see their friends, they can get all the gossip, and they can work out at the same time. Very good. And try to work them up to 30 minutes most days of the week. For older patients, you start with less, again, so start low, go slow, but don't stop. Right? Start with less time, increase more slowly. Consider physical therapy first if they have real limitations. But there's no evidence they can't be as aerobic as younger people. This is the world's oldest marathoner. He's now 102. He was 101 when he ran his last marathon. We should all do so well and look so good doing it. So what would be an example of an exercise prescription? So this is an example for Edward. I'm dating myself here. He should exercise at least 3 times a week with light intensity, 20 to 20 minutes, and he really shouldn't do yoga. Right? And then you sign it, and you give it to them, and they do it. They listen to you. So now what? Now you know all of these things. So how do you prescribe reasonably? So I was thinking about this with my damaged hand and my inability to scroll through charts. What am I going to do differently to be better at this whole medication thing? So when I sit down with the chart before I go into a room, what am I going to do differently? Well, I'm going to start looking at the meds and going, did I start this? Did I just keep it going because someone else started it and I thought, well, okay. First year medical school, reading EKGs, I learned the rule, there should be a P for every Q and a Q for every P, right? So for my patients, do they have a problem for every pill? And do they have a treatment for every problem? And have I found all the important problems and ignored all the unimportant ones, right? Is there something better? Is there something safer? And then review it with the patient and write it down so that they know I've done my work and that I care. Future solutions. This is Bob. Bob comes to our clinic every Friday afternoon and does pharmacy medication reviews with some of our patients. They love him. They love him. They feel so cared for, and they walk out of there with so much information, and it only puts my clinic behind a little bit. So it's great. They love it. They talk about him. They schedule their appointments just to see him, not me. This new annual wellness visit that's coming out for Medicare, right now some places are doing it as an RN-led thing. No reason it couldn't be a pharmacist RN-led double thing and get more bang for the buck in terms of medication reconciliation, right? The VA has pharmacy-only clinics. Oregon has pharmacy-only clinics. There's no reason we can't have some of those too. Most of us in primary care have either a weekly or a daily huddle with our medical assistants. They're smart people, right? My medical assistant's awesome. There's no reason she can't have a list and say, hey, do you know they're on that? Do they need to be on that? Useful. So take-home points. Proton pump inhibitors, chronic kidney disease, fractures, statins, increased diabetes. If you have a low non-cardiovascular risk, statins are probably okay as primary prevention. If you have a high non-cardiovascular mortality risk, it's probably a wash. Hormone replacement therapy has a real, though limited, use. Tramadol equals delirium. I said it at the beginning, I'm saying it again. Look and treat osteoporosis, cancer, depression. Prescribe exercise. So in conclusion, actually there are no safe medications, right? All those things we think are so awesome and we want to just put them in the water, nothing's safe. There are no sacred cows. So prescribe reasonably. Don't forget to diagnose. Don't minimize treatment just because someone's old. But start low, go slow. Just don't stop necessarily. And exercise, exercise, exercise. Did I say that enough? Right. Okay. Thank you. There's already a hand up. All right. Dr. Buchanan.
You talked about the association or lack of with dementia, and I wonder if you ran across anything that studied association with just memory problems, transient short-term memory issues.
Yeah, so the question is, I was looking, it was a statin question, right? Yeah, so statins and dementia question, whether or not I'd run across any research on statins and sort of almost like brain fog, like short-term memory sorts of things. It's out there. There are papers out there. I haven't seen anything that's super high quality.
Alexis?
Yes.
Yeah, so just recently in Lancet, Corey Collins and people from Oxford published an extensive analysis of statin benefit and side effects, and they have estimates for 10,000 people on the various occupations. Memory was 0.
Yeah, so I read that study. My mother-in-law actually sent it to me. So, so Corey Collins is a famous pro-statin guy. So he just, I think, regenerated the debate. I think more than anything else. But he did have this really excellent, very detailed study looking at the risk of cognitive changes in statins and came up with a no. It's just not there. We'll see. I think it's just going to stir the water some more. So we'll see how it goes.
My comment on saving your scrolling finger in your CC chart is we're considering a push to have specialists go to AFSO instead of SOAP formatted, which is what Bill Bussey did for years. Put the assessment and plan first, and you less scroll.
And to be fair, I put the assessment and plan first in all of my consult notes, as some of you know. So, Molly.
Well, with age, there's a huge intersectionality of gender because women live so much longer, and you didn't specify sex or gender for any of your recommendations, and so is there?
So for things like exercise, gosh, no.
Not
Right.
for exercise, about any of the other things.
They don't break it out. So if you look at the data, there aren't very many women in a lot of these trials. So I think that I couldn't say with any sort of scientific accuracy because women, like older people, are not studied enough.
Even though by law.
Well,
And I must
yeah, by law. There are women in these studies, just not a lot of women. Sorry. Mihai, way in the back. I'm glad you're surprised you liked it, I think. So I agree with you. I think you're right. The people who make it into studies are not the majority of my patients, not the frail elderly, right? They don't include those. It's sort of like nursing home patients. They don't make it into anything but nursing home studies. So you do have to take all those findings with a grain of salt. I think that was one of the things about the SPRINT trial, right, is that they excluded all the frail elderly people from that trial. Adam Gepner is actually going to work on that. He's great, wherever he is. So I think that's true. You take it with a large grain of salt. But I do have some really healthy older patients to whom this may apply. So you have to know it to apply it to those people to which it applies.
Thank you all for coming.
Thank you.